So we'll go ahead and get started. If you have questions or comments during the lecture, just go ahead and put them in the chat. You can use the raise your hand function as well. I just tend to notice the chat a little bit faster. So if you've had your hand raised for a while, there's a chat I haven't answered. Feel free to interrupt me, just unmute yourself and jump on in real quick. Today, we're going to begin with our first topic. And in this topic, we're trying to answer the question, what is medical sociology and why is it useful? So let's begin with talking about the sociological perspective. Here, not just medical sociology, but all sociology. This perspective is distinct from other approaches to studying variation in human life. Medical sociologists study variation in human life by studying health and illness, healthcare, and they do so in terms of social problems and social factors, instead of looking at individual issues or biological or cognitive factors. Now, it's important to note that social problems do in fact impact individuals. So we're not saying that things are not impacting at the individual level, but sociologists aren't going to necessarily be interested in this impact to the individual as much as they're interested in the shared impacts of social problems across groups of individuals. So here, sociology is going to be interested in your experience if it's similar to somebody else's experience and you have some similar characteristics. So this means that instead of asking questions about why an individual has some experience or what that experience is, sociologists are going to ask questions about why there are patterns of similar experiences among individuals with similar social circumstances. So here, not necessarily why this individual has the experience, but why do these individuals have this single experience? So when medical sociologists look at the impact of social problems and social factors, they can look at a few things. So they can look at how these social problems and factors impact the likelihood of health or illness. We can also look at the experience and perceptions of health and illness. Other medical sociologists examine things like who provides healthcare, how that healthcare is provided, and to whom. And then social problems and social factors also impact the healthcare system. So here at the institutional level, and that's also going to be something that medical sociologists are really interested in. So here, think of shared individual problems or shared institutional problems as your social problems. So let's look next at an example of a medical phenomenon that's relevant to research in sociology, but also in other fields that study health and illness. So let's look at the case of obesity. Here we're looking at something that's been defined as a medical problem by medicine, but we're going to look at how this medical problem can also be considered social. So let's start with defining it as medical. Medicine is going to look at obesity as measurable, biological, and pathological. Pathological here, meaning this is illness. So when medicine is conceptualizing obesity as illness, they're particularly interested in the idea that obesity is measurable through things like BMI, weight, and mass. And then they're going to be really interested in individual things that can fix obesity as a medical problem. So things like a patient taking medication, changing what you're eating, changing your exercise patterns. All of these things are going to be really important factors for medicine. From a psychological perspective, here looking more at the cognitive emotional aspects, we could conceptualize obesity in terms of what we call maladaptive coping, or sometimes what we call a trauma response. So obesity here is a behavior that's representing something cognitive, some cognitive response to something else. So either you're having a stressful circumstance and your form of coping is, say, stress eating. If we were to look at the same behavior, stress eating, in terms of trauma, psychology might identify stress eating as mental illness. We know that to some extent this has been defined as a mental illness because we have these programs like Overeaters Anonymous, and we do define binge eating disorder as a psychological illness. But again, participation in these programs is individual. The problem is individual. So moving away from the individualized approaches, sociology is going to be a little bit different. Looking at the same phenomenon, obesity, sociology might look at obesity instead as important to US society because it's been defined as important in terms of defining it as illness. So in this case, we're talking about the social construction of illness. The other way that sociologists can look at obesity is by looking at obesity as deviance. So here looking at obesity not as illness, but as something representing a deviation from the norms and values surrounding the body, specifically this valuing of thinness. Now, if you've had a chance to look at the title of your textbook, you might have noticed that it says we're taking a critical approach to the sociological study of health, healthcare, and illness. So we already said that sociology can look at obesity in these two ways, right? So obesity is important because it's been defined as important and socially constructed as illness, and obesity representing these norms and values surrounding thin bodies. So a deviation from norms and values. Critical sociologists take a slightly different approach. So power is something that sociologists are very interested in. But critical sociologists are interested not just in power existing, but also things like the reproduction of power and inequality over time. So using our same example, obesity, the critical sociologist might say that defining obesity as illness or deviance produces and reproduces these existing power structures, which happen to favor thin people due to our existing norms and values here in the US. So critical sociologists are questioning the pathologizing of obesity, and they're also going a step further to look at how these individualized medical and psychological, quote, solutions to this, quote, problem of obesity don't actually eliminate obesity among the population due to numerous other social factors. A critical approach here might question the usefulness of solutions that are not achievable for most of the population due to things like financial constraint and work obligation. So you have, on the one hand, this issue that most people simply don't have the time or money to invest in things like fitness or wellness. But a critical approach might also question the medicalization, really this pathologization of obesity in the first place, asking, is this even a problem in the first place? Is this something that needs to be fixed? Or is this just bodily variation? So asking, does everybody need to be thin? We can see the importance of medical sociological research when trends in wellness shift. So for example, BMI is starting to really go out of fashion, and it has been for a little while. And regardless of medicine's adherence to this concept and the idea of obesity as illness, public sentiment surrounding obesity and thinness is really starting to push back against this idea that obesity is pathological, is bad, is negative. We also have research showing that BMI doesn't actually tell us very much about how healthy or unwell someone is. It doesn't even tell us very much about their level of fitness. Why? Well, for one thing, you can have a very rigorous daily workout regimen and excellent test results in terms of things that are considered reasons obesity is bad. So things like cholesterol, blood pressure, etc. And you can still be flagged for being overweight or obese when you don't have high cholesterol, you don't have high blood pressure per BMI standards. Similarly, being thin does not necessarily reflect fitness or a healthy diet at all. In fact, thinness can also be an indication of malnutrition, which is, I think that we would all say probably not more healthy than overeating. Maybe we have two things that could be considered a deviation from what we've conceptualized as healthy, but we definitely can't say that thin is healthy. So here, really getting comfortable with confronting the idea that things that we've defined objectively might not be so objective. Now, medical sociological research is traditionally conceptualized into one of two types. So we have sociology in medicine and sociology of medicine. Sociology in medicine is research that's of interest to medical professionals and also medical educators, medical scientists, things that are going to be important to medicine as an institution. The sociology of medicine is going to be of interest really to the general scientific field of sociology. And importantly, sociology of medicine might not just be of disinterest to medicine. In fact, medicine might sometimes have a vested interest in arguing against the sociology of medicine. Right, so silencing it. We can ask why. Well, sociology of medicine might not be useful to medical professionals, for example, if it's critiquing medical practice. In fact, it might just come off as offensive to medical providers. So sociology in medicine tends to work really well with other medical professionals. Sociology of medicine tends to be a little bit polarized from other health researchers, health professionals. And most of your critical sociologists are going to be in this sociology of medicine camp. So let's look at an example of one issue, first from the perspective of sociology in medicine, then from the perspective of sociology of medicine. So if we start by asking what medicine might view as useful sociological research, looking at compliance from the medical perspective, patient compliance is vital for successful medical practice. Also vital for medical treatment, right? So if your patient's not listening to you, they're not taking their medication, and that medication is supposed to get them better, then you can't really practice. It's kind of the same limiting factor. If your patient won't have surgery and operating is the way that you do your job, well, you can't do your job. So sociology in medicine is going to examine compliance with this medical perspective in mind. And they're going to try to find social factors that might be useful to solving this problem for physicians. So how do you get patients to better comply? So here we're examining the barriers to patient compliance. But we're not arguing against the assumption that compliance is necessary and good. We're going along with that assumption because that's what medicine says. Now, if we move to sociology of medicine, so now asking not about medicine, but instead, what is the greater field of sociology view as useful medical sociological research? Well, we know that the greater field of sociology is interested in these issues of power and inequality. So if we're looking at compliance, we might look at patient compliance in terms of physician control over patients. So here, trying to contribute to the traditional sociological literature on deviance and social control. The idea here would be that physicians offer something that patients cannot obtain on their own. So patients don't have very many options. They must be compliant or they risk being denied treatment in the future, which gives physicians a lot of power. They hold the power to help people feel better when they don't have any other options. Here, instead of looking at compliance as inherently positive or necessary, we can critique the idea that compliance is positive or necessary. We can even take it one step further and we can critique the continued endorsement of compliance as positive and necessary. This is because the sociology of medicine is also examining barriers to compliance, but it's doing so not with the assumption that compliance is necessary or helpful to the patient. So it leaves room to explore the patient experience, meaning they can explore things like mistrust of medical professionals, experiences with bias and discrimination in the clinical encounter, and then whether patients have an understanding of a potential treatment as helpful or a belief that this treatment is instead useless. So here the reproduction of power occurs when patients are, say, blamed for being non-compliant, but in all actuality, their compliance has nothing to do with them not wanting to get better. So they're not getting better, which is keeping them in this lower position in the social hierarchy. And also allows for a situation where physicians don't have anyone powerful enough to argue against them. So typically, if you have a mistrust of medical professionals, you're not complying because of that reason, you're not going to be trying to start a new field of medicine. You're just going to stop going to the doctors. So for medicine, the things that should be signs that maybe we're reinforcing structural inequality are instead just individual issues where patients are not following instructions, so it's not their fault that they can't be treated. Now, interestingly, even though pretty much every medical sociology textbook available really emphasizes this distinction between sociology in versus sociology of medicine, it's increasingly less common for medical sociology to neatly fit into either camp. Part of this is because medical research is becoming more socially conscious. And the other reason is because we have so many subfields. So we see a blurring of the lines in one sense in the increasingly interdisciplinary work in medical sociology. So the incorporation of themes from both in and of medicine to get a more holistic picture. So now we're starting into the second part of our question, not just what is medical sociology, but why is it useful? So first, medical sociology is really, really useful for interdisciplinary health research. And when it's useful for interdisciplinary health research, it usually falls into one of three categories. So we have epidemiological research, social psychological research, and network analysis. Starting with epidemiology. Epidemiologists study health disparities, and they're going to do so in terms of patterns of health and illness, patterns of disability in a given population. They're going to look at things like environmental factors surrounding that population. Environmental, like your physical environment. So for example, say they're finding that a lot of people have a similar type of cancer in one geographical area. So epidemiologists might start to look and see if there's some sort of carcinogen that they were being exposed to on a community-wide level, right? Maybe there's some sort of manufacturing plant that's polluting the water or something like that. A really good example, ongoing example of this is the crisis that was discovered in Flint a few years ago, but is ongoing. Right, so there was lead in the water pipes and a lot of people were getting sick. And they found that there was an environmental cause. That environmental cause was that Flint did not have an updated plumbing system, right? So these lead pipes didn't just get there on their own, and they weren't just still existing because of no reason. They were there because of active policy decisions to not update them. So, having not updated plumbing in a very long time, even though it was well known to need updating, for the epidemiologist is going to be kind of an issue. Your public health epidemiologist might stop here at that environmental cause. Okay, we need to fix the lead pipes. The medical sociologist is not satisfied with that answer, that people are getting sick because of the lead pipes. So an epidemiological approach to medical sociology, so stepping outside of public health, would investigate the existence of the lead pipes in the first place. Why weren't they replaced? Did people know? When did they know? And if they knew, again, why were the pipes not replaced? So here you can see epidemiology, a field that is very traditionally public health, is also something that medical sociologists are very involved in, but they're taking things from a little bit of a different angle than public health is. So here, contributing to really wider interdisciplinary knowledge about things like water pollution. Social psychological research tends to focus on the micro level, so looking at things like social interaction, emotions, and identity formation. Social psychology is interesting because you have psychological social psychology research. But you also have sociological social psychology research, which is going to look at what things that psychology has defined as objectively cognitive, possibly as attached to some biological mechanism. And instead say, well, that might not be the case. Or in addition to this biological mechanism, something external is triggering that internal mechanism. This research is pretty useful for understanding things like the impact of interaction in the clinical encounter as really important for patient health outcomes. So a lot of social psychological research in medical sociology is going to focus on the provider-patient interaction, specifically how interactions with providers in a clinical setting can leave patients feeling discriminated against, judged as morally inferior, and sometimes even traumatized. This is of particular interest to social psychology because a lot of times identity is going to be important in these negative interactions. So for example, when a medical provider discounts the significance of a patient's identity, particularly for shaping the provider-patient interaction, they might violate a patient's trust. A common example is the misgendering of trans and queer patients, which can happen when a provider refuses to use a patient's preferred pronouns, but also in less direct ways, like when medical forms equate gender with a binarized conceptualization of biological sex. So they say, identify your gender, male, female. That's not gender, but okay. Social psychological research in medical sociology can also provide insight about these interactions at the individual level and how they play a role in greater systemic inequality when they reinforce existing power hierarchies. So looking at things like microaggressions. Network analysis is also extremely interdisciplinary, the most obvious reason being that it's both a method and a paradigmatic framework. So network analysis examines social interaction while accounting for the context of a social network. It does this mathematically when you use network analysis as a method, but it's also informed by network exchange theory So this context is vital. There is no understanding that interaction operates independently at all. If you're interacting with someone, the extended social network is inherently going to have an impact on that interaction. This is going to be really useful for determining systemic effects. It can also be used to look at things like multi-level effects. What does multi-level mean? Well, it means like in addition to things like who interacted with whom, network analysis can look at interactions between, say, an individual and an institution, or even between two institutions. So this could include things like examining ER admissions while accounting for insurance providers and patients. So a lot of times you're going to get maybe just examining ER admissions. Maybe you're looking at ER admissions and patients. The network analyst is going to be really interested in also adding that insurance provider and anybody else that kind of is impactful here. The other big focus of social networks research in medical sociology is the internet, particularly social media. That's because social media is an increasingly popular forum for discussions about health, illness, and disability. And it's been a staple for the disabled community for quite some time. So a lot of health social movements research uses social network analysis. Now, while medical sociology is becoming more interdisciplinary, most of the current work is still going to be tailored to the field of sociology and structured as a contribution to sociological science or literature. And that's why I say that despite this emphasis in medical sociology courses and even in our overview of medical sociological literature about sociology in versus of, the majority of medical sociological research is sociology of medicine, right? And then we have sociology in medicine, which consequently ends up being largely interdisciplinary. So your medical sociologists in sociology departments are, for the most part, going to be looking at the sociology of medicine, or they're going to be looking at in and of together. We're going to ease into the semester by first looking at the more interdisciplinary work in medical sociology, focusing on this macro and the epidemiological approaches. So looking at variation in population health when we move in module 2. In module 3, we're going to get to start exploring work from each of these major subfields in medical sociology. So we're going to use theories and concepts from sociologies of disability and diagnosis to explain variation in health, illness, disability in the population. We're going to talk about things like experience. So we're going to build on the information we gathered in module 2. And we're also going to look at social constructionist and medicalization frameworks as an explanation for patterns of variation in population health. So module 3 is largely going to focus on social and environmental factors impacting health disparities, looking at institutions other than medicine and spending a lot of time discussing the patient context. What about healthcare, though? So once we establish a good understanding of health disparities in terms of macro and micro approaches in modules 2 and 3, we're going to move to the meso level, and we're going to look at healthcare as an institution that is independent but has great influence over other institutions. So really the social system as a whole due to its position. So say we conceptualize the US social system as a network of institutions. network of institutions and social groups. We can look at healthcare as one of, if not the most central node in that network, impacting everything else. We will have gotten a pretty good understanding of our other nodes in our previous modules. We're going to have kind of glossed over healthcare and other components of the medical institution. This is because we're on a quest, right, to understand how patients exist and how they're impacted by this position in the larger social system. I'm going to pause here to point out that this means that we can look at modules 2 to 3 as falling under the sociology of medicine approach, while module 4 will shift back into sociology in medicine. The sociology of healthcare, the study of medical professionals, and the study of medical education are really useful for understanding how social problems impact doctors and their training and practice. Notice, though, that we still have one subfield here on the screen, health social movements. We're going to end our semester with a discussion of issues impacting medicine. Really this exploration of sociology in medicine that's separate from sociology of, so not in and of together, with another dose of sociology of medicine. So really rounding it out. We're going to look at health social movements and medical ethics to bring our exploration of sociology of healthcare into our greater discussion of this health system, right? So we've moved briefly to this meso level, and we're looking really at issues that are important to healthcare, important to doctors from the perspective of people on the inside. Then we're going to place this back into the context of what we've been discussing all semester about patients and other institutions. So now that we know about social problems impacting medicine, what does this information mean in context of our more general social problems? So things like racial and economic inequality. Other subfields in sociology have broken off from medical sociology in the sense that they've formed their own sections in the American Sociological Society, or ASA, also some of our other professional organizations. But their work still remains extremely relevant to medical sociology, and some of them still remain affiliated with medical sociology and kind of the offshoot. So we're going to draw on concepts from some of these subfields this semester. So you're going to touch on concepts and theories used in disability studies, sociology of alcohol and drug use, environmental and biosociology, sociology of mental health and illness, and the sociology of embodiment. So if you're wondering why this might be important for you right now, if I turn your attention for one moment to the final project. For the project, you need to focus on a social problem that has relevance during the COVID-19 pandemic. But a lot of these problems were exacerbated, not caused by the pandemic. So you can use what we've discussed today to kind of help guide your discussion about a topic for the project. So maybe you aren't quite sure of your topic, but you are fairly sure of your sociological interests from your experience in other classes. So maybe you're really interested in criminology. So sociology of alcohol and drug use might be a good focus for your project. So ask yourself, do your interests fall under any of these subfields? Narrowing by subfield can be a really, really helpful first step to identifying a social problem of interest, which is going to be kind of the basis. Okay, so to wrap things up here, I've situated my own research as a medical sociologist in terms of subfield and topic. And I've provided you with this information for a few reasons. So first, I want to emphasize that one or a few interests can be relevant across many areas of medical sociological research. Right, you can see here that my research certainly does not fit neatly into one category. Yours might not either, and that's totally fine and okay. Additionally, for the purposes of this class, I want you to go ahead and try to eliminate the word objective from your vocabulary. And that's because medical sociology requires us to confront the subjectiveness of things that are presented very often as objective. So try to get comfortable with confronting the notion that medical facts are non-social. We're not going to say that medical facts don't exist, that they're fake, but what we're going to start doing is examining medical facts as social facts, meaning they exist, they're real, sometimes even written, published, codified, but they're socially constructed and are sensitive to change if new facts emerge. So confronting the idea that because we have an objective measure for something like BMI, that remains an appropriate and objective measure of health. Additionally, we're going to question the notion that all facts are created equal because, well, they just aren't. Some medical facts are going to be stickier than others. So we generally accept that things like cancer exist. And when we're diagnosed with cancer, people don't tend to say things like, oh, well, cancer doesn't exist. I'm sorry that you feel bad, but really it can't be cancer. Have you tried essential oils? That sounds pretty ridiculous, maybe even a little bit rude. But the reality is that this may seem absurd for something like cancer, but patients with other diagnoses very often do receive these kind of comments. So mental illness, psychosomatic illness, and contested illness diagnoses are perceived very, very differently than a cancer diagnosis. They could be stigmatized. And sometimes even medical professionals question whether things like ADHD, depression, polycystic ovary syndrome, myalgic encephalomyelitis, chronic fatigue syndrome, other post-viral syndromes, fibromyalgia, all these things you may not have heard of exist. They do exist, but medical professionals might question it. Sociologists might too. We're actually going to encounter a few sociologists this semester who take the questioning to the extreme, suggesting that ADHD and depression might not exist. So you'll have the opportunity to offer your critiques of that work. And then the final reason I'm providing you with this info is just so that you know which topics I can be most helpful with, and to give you a little bit of insight about my positionality. So as we're walking through the lectures, if I say something and you're like, oh, I wonder why she thought that way, this is largely what's biasing my lectures. So if you take a different paradigmatic approach, what I'm saying here is it's okay to bring up that there are other approaches and to challenge things that I'm saying in class in a constructive way, and I encourage you to do that.